Nclex. And I found a bunch of interesting questions that could be also present in the RN exam. So let's go over these questions. I'll read the questions. I'll give a minute, a moment to think in the answers, and I'll defend what I think about the answer. Remember that those tests don't have answer key. We need to find the right answer, or at least the best answer. It has a real English test. The first question say, the nurse is assisting with the admission of a client who is scheduled for a colon resection. Which of the following statements made by the client will be most important for the nurse to clarify? I have urinary incontinence when I sneeze. I had a successful cataract surgery 2 years ago. I take acetaminophen for occasional headaches. I usually have a few glasses of wine in the evening. So analyzing the question, uh, the first option, the client is going to a colon resection, probably a colon cancer. We don't know the gender or the age, but we need to find of all these four, what is the most important that could affect the surgery that the client is going on, because we are doing the admission. So we need to find of these four options what could modify, influence, positive or negatively, especially negatively, the surgery. So the incontinence, when the person sneezes, has a leak of urine. There are four types of incontinence: the stress incontinence, the urge incontinence, the overflow incontinence, and the functional incontinence. Of these four types of incontinence, the client that have a leak of urine when sneezing, coughing, laughing, or lifting weight is the stress incontinence, which is more common in women postmenopausal that has atrophy of the pelvic floor, especially if had um, multiple vaginal birth, and the one that produced this symptom that without any warning, the client, when increases the intra-abdominal pressure, leak urine. And you know that the Kegel exercise are good to be recommended independently by the nurse to those clients. Kegel exercises can be done if the client has no surgery, because it is a question in NCLEX that a client has a recent surgery, so 1, 2, 3 days ago surgery. You don't recommend Kegel exercises, which is contraction of the pelvic floor muscles, uh, neither in men or women, because can produce bleeding, can produce irritation, inflammation. But if the person has no surgery and has incontinence, stress incontinence, the Kegel exercises are okay, you know? And how can this influence the surgery? How can this influence, okay, the post-operatory, the colostomy the client is going to have? In reality, there is no relation. So this option doesn't look the most important to follow. It's an inconvenience, should be addressed, but it's not the most important, because you need to find the most important that could affect the surgery. Is super important that you study your type of incontinence for your test, because are frequently, but very frequently tested, okay? Very frequently tested, okay, topics, the type of incontinence, okay? But well, I review stress incontinence. I had a successful cataract surgery 2 years ago. So obviously is completely healed, and the fact that it was successful ruled out as a priority because there were no problem of bleeding or anesthesia, etc. Acetaminophen is a safe medication to take if the client have occasional headaches, as any person can have. Those are functional headaches, and for that reason is not a problem. So ruling out, the answer should be 4. And you know that alcohol is always a problem, is always a risk factor. And when they say a few, it could be related with the denial and denial, okay, that the client with alcohol, the alcohol problems can have. And the alcohol can produce a liver damage, and the liver has to do with the coagulation, because the coagulation factors are many of them synthesized in the liver, and this is something that could influence the upcoming surgery. So that's the rationale for answering this question. In my opinion and in my experience, can you have a similar question like this in your English? Absolutely. You know why? Because it is one of the question of the level of complexity of question that is considered difficult, because you need to apply your knowledge in these options, because recognizing that the alcohol, not because the alcohol is because there is no problem with the surgery and anesthesia alcohol. The problem is that the alcohol could be affecting the liver and the coagulation, and this is the way that it affects the surgery. The next question: if you have something to comment, if you have something to intervene or to ask me. I know that is a very simple question, a very simple explanation, and you should be satisfied, no problem. But if you have any doubt, ask me. Next, the nurse is caring for a client who is scheduled to have an arterial blood gas sample obtained. Which of the following tests should be the nurse anticipate will be performed prior to the procedure? And they mention 4 tests that has proper names: Coombs, Shillingham, and Allen. So all you should know that the Allen test is the test that should be done before um, pricking on the radial artery. You need to remember that the hand has 2 arteries. Okay, suppose that it is the this is the thumb. Okay, this is the thumb. You have 2 arteries. No, and you have an artery in the side of the thumb and an artery in the side of the pinky finger. This is the radial artery and is superficial, can be palpated. This is the ulnar artery and is deep, is very difficult or impossible to palpate. But these 2 arteries communicate in the hand, so make connections. Yeah, and both irrigate the hand. If you are going to introduce a needle, if you are going to introduce a needle in the radial artery, which is the one that you can palpate and you can pierce, you can, penetrate, can prick to obtain the arterial blood. Yes, you need to be sure that the backup, the spare artery is present, is competent. So the purpose of the Allen test is to verify that the ulnar artery is patent, is working, because there is a risk, always there is a risk of damaging, okay, the circulation of the radial artery. And as a consequence, then the radial artery will not be sending blood to the hand, but then you have the ulnar artery like an spare artery. To do the Allen test, you need to ask the client to make a strong fist, close the hand in a fist. The purpose of this fist is to blanch the skin of the palm of the hand. At the same time, the hand of the nurse should be pressing at the same time in the radial artery and the ulnar artery at the level of the wrist, at the level of the wrist. Yeah. And after you are pressing, the client has the fist down and you are pressing the two arteries, then you are blocking the circulation. You are blocking the circulation of the blood in the hands. And so when the client opens the hand is going to be very pale. Is going to be very, very pale. So what you do now, you release only the pressure in the ulnar artery. When you release the pressure in the ulnar artery, so this hand is going to be raised. You keep the pressure in the radial artery, but then you release that, and then when you release this pressure, you see how the blood return to the hand. Yeah, and it tells you that the ulnar artery is patent. You keep the pressure on the radial artery to block the circulation from radial artery. So in case that the radial artery is damaged, this is what you are going to have: circulation to the hand through the ulnar artery, saving the blood flow in the hand. So to summarize, they can ask you the Allen test as a concept if you know the name and why it's done. They can ask you which artery is testing the Allen test, the radial or the ulnar. The answer is the ulnar. Okay, the radial is not tested with the Allen test. And the third question that you can have is put in order. They give you the steps of the test. Remember that I say first make a fist, then compress at the same time the radial and ulnar artery. Then make the clients open the hands to verify that the fist make a blanching in the skin of the palm. Then raise or release or elevate the pressure only on the ulnar artery and observe for the return of the blood, which is a positive Allen test that allows you to mess with the radial artery, okay? Because you know that you have a backup artery to irrigate the hand. Any doubt? No? Everybody understood the possible question related with Allen test? Okay. Nurses can do the Allen test. Nurses can obtain a specimen of blood of the radial artery. The nurse is contributing to a staff education program about client confidentiality. Which of the following information should the nurse suggest including? Now I want you to help me. I want your opinion. I want to explore your opinion. So tell me, each item, its number, you need to decide if it is true or false. Okay, the client is the sole owner of the client's medical record. True or false?
False.
False. The medical records belongs to the hospital. The client has the right for a copy, but the medical record belongs to the hospital for the facility. The owner of the medical record is the facility, it's not the client. The client has the right to request, the client or the proxy, no, the power of attorney has the right to request a copy of the medical records, but is not the owner of the chart. So you need to know that as a nurse, there are different scenarios, okay, where the confidentiality can be violated because somebody, the son, the daughter, the spouse of a client demands you to check on the client's medical record. You cannot allow that. And if the person is authorized to know about the medical records, need to check the copy provided by the hospital, not directly in the chart of the client. So cannot sit in the computer to browse the client's medical record, or cannot open a paper traditional chart to explore that. Unneeded computer generated worksheet must be shredded at the end of the shift to ensure client confidentiality. True or false?
True.
True. When you work in a hospital, especially there are electronic and medical records, when you arrive to your shift, you can imprint like a summary of the orders, medical orders of the client, and information that is pertinent to do your work, and you can keep those paper with you, and are very good, very very good to do when you arrive to print your cardex, to your summaries, and of course at the end you need to shred them in the nursing station, to be sure that this is not rolling all over all over any place. Um, Personal computer password may not be shared with anyone. It is an absolute, including other members of the client's health team. True or false?
True.
True.
This is true, because even another RN, MD, doesn't need to know your password. It's access to the medical records for authorized person, the other RNs or the doctor, should be done with their own password. I forgot my password. Can can I borrow your password? No, because whatever is done in this moment in the chart is under your name. Okay, so never share your password with anyone, not even your buddy, your best friend, etc. So it is true. Okay, so it's one of the cases that an absolute, it is correct. Okay, remember that the rules we have been talking, and we see absolutes like anyone, nobody, always, never. We suspect that the option could be wrong. Okay, in that case, for confidentiality, is 100% correct to use this absolute term, because there are exceptions of the rule. Keep your voice low when speaking with the client, because direct interaction with clients must be kept as private as possible. Of course, that is true. Okay, of course, that is true. We need to be very careful that, if there is a room with two beds separated by curtain, when you're talking to this client, okay, the other clients could be hearing, or the other people that are sitting there, and then you are disclosing very private information, okay, to the other people. Medical information about the client may be shared with a police officer, a policeman, okay, the authority, what we call the authority, the police, no, who brought the client to the emergency department. What you know about this? True or false?
False.
False.
Is
False.
false. Is false. The police need an order to obtain information from the client. Like 4 or 5 years ago, a nurse in New York, in a hospital in New York, received a client brought by the police. In the client was involved in a motor vehicle accident. The clients, we suspected the clients had consumed alcohol. The nurse ordered, as a protocol, the alcohol level in blood. The police who brought, and it was in charge of carrying the case of this accident, demanded the nurse to inform the result of the blood level, alcohol blood level. The nurse, knowing, because was a nurse knowledgeable about the law, refused to provide this information. The police arrested the nurse, and it was a very famous case. Was in the news. Okay, it was a very famous case, and of course, at the end, the was evident that the police officer were abusing of authority, and was scolded for this kind of stuff, and the Department of Police of New York asked for for, for excuse of this behavior. So it's important to know that sometimes we can even be in, you need to be diplomatic. You need to know how to deal with the police. The police are our friends. The police are our friends, but police can have a misinformation, can be have personality problems, or can have a bad day, and you can have conflicts one day with the police. It is a possibility. So we need to know your law very well, because at the end the law is imposed. Okay, the charge nurse in a long-term care facility has been advised that the following assigned clients will be admitted during the shift. The charge nurse should assign the only available private room to the client with. So it's a case of isolation because our four infectious diseases. We have hepatitis C, varicella zoster, pneumocystis pneumonia, pneumocystis jirovecii pneumonia, and cytomegalovirus. You should know that all the hepatitis are standard precaution, and standard precaution infections don't require isolation, don't need private room. Okay, the only exception of this is a hepatitis A in a client that is incontinent, which is very rare. Hepatitis A is a disease of school age, adolescent, and young adult. ¿Cómo se escribe young? Young adult, okay? Young adult. ¿Sí? Entonces, neither school age, adolescent, and young adult used to be incontinent. That's why it's very rare that you need to place a case of hepatitis A in contact precautions because the client is incontinent. The Center for Disease Control says that hepatitis A is standard precaution and only requires contact isolation if the client is incontinent, which is a very rare situation. So all the hepatitis can be memorized at standard precaution and don't require isolation. The pneumocystis jirovecii pneumonia occurs in patients that are immune suppressed, cancer, chemotherapy, transplant, AIDS, etc., and are also standard precaution, cannot be passed from individual to individual. This is the normal flora a producing disease in a person with immune suppression. Immune competent people, like the nurse, is not susceptible to this bacteria. And this standard precaution doesn't, this pneumonia does not require isolation. There are several pneumonias that don't require isolation. The only pneumonias that requires isolation are streptococcus pneumonia, the Haemophilus influenza B pneumonia in children, the um, the walking pneumonia, the mycoplasma pneumonia, y the plague pneumonia. Please try to remember these four agents in pneumonia that requires droplet isolation. But the other pneumonias, example, viral pneumonia, pneumonia by gram-negative, like for example, Klebsiella pneumonia, pneumonia by Legionnaire disease, Legionella, pneumonia by pneumococcus, pneumonia by pneumocystis jirovecii, pneumonia by anthrax. Those pneumonia don't require isolation. Nclex is very strict in your knowledge of isolation and is important. It's for test purpose. It's important that you remember that pneumonia is the P of a Spider-Man, okay, of a Spider-Man, Yeah, Spider-Man, the pig, together with pertussis, no? Pertussis and pneumonia. But they are not all the pneumonias. Only these four pneumonias are the one that requires isolation in droplets. The other pneumonias don't require that. Okay? It's important. Cytomegalovirus is also a standard precaution. Cytomegalovirus produce like a viral, is a virus, no? Can produce a benign viral disease like a common cold with enlarged lymph node. But in immune deficient clients like AIDS, cancer, or fetuses, don't forget that the fetus, okay, the fetus is an immune suppressed individual, no? Can produce damage in the retina and the brain. So cytomegalovirus is not good for clients with AIDS, transplanted clients in immunosuppressive therapy, or pregnant women, but it's a standard precaution. On us immune competent people, cytomegalovirus is like a common cold with large lymph node without other consequences. But in those clients and in the fetus, immune suppressed client in the fetus can produce brain damage and retinal damage. It's the most important to know about cytomegalovirus. So it's not good to have a pregnant nurse assign a cytomegalovirus positive client. It could be a question. But obviously the varicella zoster requires isolation. Okay, chickenpox. Chickenpox requires airborne precautions. Okay, airborne precaution. So it's an easy question, but just a brief review to emphasize some concepts that being in English in questions, and in English are very picky with the details of infection control. I don't know if you are aware of that, but the Center for Disease Control have a document that you can download in the CDC, which is super important. Okay, this document, okay, can be downloaded in the web page of the CDC, that are the guidelines for isolation precaution. Okay, and is the last. Okay, they are actualized. You see that you have actualization continuously. They have a many many good stuff, but they have a table in alpha order of the most common diseases, and then they tell you, okay, that, okay, for example, cytomegalovirus infections, okay, standard precaution, yes, or for example, the pneumonia, you go and then you can verify all the stuff that I'm telling you, no? HJKLM, pneumonia. So you have to all the pneumonia, and you see that they are, telling you the pneumonias that are, most common. Okay, and okay, for example, the pneumonic plague that require droplets. Okay, the all these pneumonias are the pneumonia por Haemophilus influenza is droplets. The meningococcal pneumonia droplet, of course, meningococcus droplets. You have much more information here, no? Mycoplasma is droplet. So, yeah. Pneumococcal pneumonia is standard. Pneumocystis jirovecii is standard. Staphylococcus is standard. Streptococcus is droplet. And viral pneumonia is standard. You see that? So remember that you can find, if you have a contradiction between what is said in a question bank, a book, etc., the last word is Center for Disease Control of any polemic, any contradiction that you find. Okay, very good. The next question. The nurse is contributing to the plan of care of a client with COPD. Which of the following interventions should the nurse suggest including in the client plan of care? Restrict fluid. Obviously, there is no need of restriction fluid in COPD. The fluids are restricted in certain situations. For example, if you have a client with heart failure and fluid retention, you can have fluid retention. If you have a client with renal failure, okay, you can have fluid restriction. If you have a client with hyponatremia, dilutional hyposodium, hyponatremia, you can have a fluid restriction. Those are examples of the clients that require fluid restriction. But in general, the majority of the clients, instead of fluid restriction, require, fluid encouragement. And it is a nonsense in COPD. The respiratory problems benefit from the fluid because it fluidifies the secretions and it's easier to remove secretions from the lungs. So no, place the client in low Fowler's position for meals. Guys, you cannot eat food, okay, recumbent on bed because you can aspirate. You need to eat. If the client is on bed, you need to elevate the head of the bed to a totally high Fowler position, 90 degrees. You need to eat sitting. It is a nonsense option. Provide the client with high carbohydrate diet and high carbohydrate snacks. So here could produce confusion because the patient with emphysema, especially, they lose a lot of weight. They are very thin, and the diet should be hypercaloric, and it could bring confusion. Probably any majority of us are carbohydrate phobics because we are overweight. We are overweighted, and for that reason, we could be not scientifically based carbohydrate phobic. And some student could be answering this question by based in that, no? But remember that broccoli is a carbohydrate mainly. Remember that an apple or lettuce is carbohydrate. Okay, so there are many carbohydrates, good carbohydrates and bad carbohydrates. So you have this option there, and the other is provide the client with a small. I think there is a microphone open. Provide the client with small, frequent meals and schedule rest periods before and after the meals, which sound very attractive. The reason for what this option is incorrect is that the carbohydrates, all the carbohydrates that you eat, transform in the intestine in glucose. And the only carbohydrate that can be in the blood is glucose. And it's good. It's good. You need to have glucose in your blood because nature or God, whatever you believe, decided decided that the normal fuel of people, of humans, is glucose. So the normal fuel that the cells of the tissues and organs use to burn in the mitochondria to produce ATP, the energy that we need to stay alive, is glucose. Glucose is the normal gasoline, the normal fuel of the body. So thanks God, we ingest around 60% of all the food that we ingest carbohydrate. When you are having qué sé yo, a carrot, when you're having a broccoli, when you're having, a bean, when you have, those are carbohydrates, and they are very good carbohydrates, and it should be around 60% of your diet. And the glucose of your blood, okay, is good because it's the correct fuel to produce ATP. Okay, but in the case of the COPD, it brings a problem. When you burn the glucose in the mitochondria, you produce a byproduct called carbon dioxide, and the client with COPD have excess of carbon dioxide. Normally, usually their carbon dioxide levels is 50 milligrams because they have obstruction to breathe out, and for that reason they retain carbon dioxide. For that reason, a increment of carbohydrate in the diet above the normal will increase the production of carbon dioxide, which is not convenient. So those extra calories that decline with COPD requires should be given as good fats. They are good fat. Okay, olive oil, peanut butter, avocado, nuts, tree nuts, etc. contains wonderful fats, very beneficial fats, and those are an excellent source of calorie. Have a double of calorie, okay, more than double of calories than the carbohydrate. So this is the main source of increment of calories inclined with COPD instead of normal carbohydrate. Okay, no increased carbohydrate. And this is the rationale for this mild restriction of carbohydrate inclined with COPD. When we give a food, the food needed by the clients, when we did the food in a small but frequent meals, it is good because the stomach, the belly, the tummy is not going to be, a very bloated, very full, and then the clients can breathe much better. They're much better. And when the client is going to eat, having this exercise like continue physical effort to breathe because they labored respiration is good to have rest. And during the meals, the client should be receiving oxygen to give facilitate the chewing and swallowing process, because if you are too short of breath while you are chewing and swallowing, you cannot breathe, and then the client refuses the food because it prefers to breathe. So that's why the best option here is number 4. I insist, based in my experience, that an RN can have similar question in his or her English. The nurse is reinforcing teaching with the parents of a child who is scheduled for surgical repair of hypospadia in 3 hours. The nurse should reinforce that intended outcome, desired outcome, what you want to happen with this surgical repair of hypospadia is relief from pain, relief from bladder obstruction, the ability to void while standing, the ability to achieve an erection. What do you think? What is your opinion?
3?
You say
Yeah,
three.
3.
Three. I agree. I agree. When in the PP, there is a hole in the base of the PP. Yeah, there is a hole in the base, instead of being in the tip of the PP. There is a hole in the base of the PP. The client cannot pee standing because it's going to be a mess. No? And you know that boys learn to pee, okay, standing. Understand? Boy standing. Yeah, that's the right answer. So good. So notice that you need to know what is a hypospedia, and the correction of that is should be done before the boy, because this is of boys. No, hypopedia only happens in boys. The boy have this problem solved before potty training. Boys learns to pee in the toilet, imitating the, the older brothers and the father. Yeah. So before this training, the hypopedia should be corrected, because it could be a question: when should be corrected a hypopedia? Before potty training of the boy. Makes sense? Okay. This is the main purpose of that. With hypospadia, the client can have erections. It's not painful. It's not obstructive. Okay, but is unable to pee standing. The nurse is caring for a client who has an order for a sputum specimen for culture and sensitivity. Which of the following actions is correct should be taken? Request a prescription for a bronchodilator to be administered before the specimen is obtained. There is no need, there is and at all, there is no need of a bronchodilator to obtain a specimen of sputum. Usually it is done when the client already produces a sputum because the client has pneumonia, bronchitis, tuberculosis, whatever is having that produces sputum. But sometimes the client is needed a sputum specimen and the client is not expectorating, is not producing a sputum. So you increase the intake of fluids to fluidify the secretions, and what the doctor can order, what the doctor can help you, is prescribing a nebulization. You know what is a nebulization? When a liquid is nebulized like a fume, like a mist, and the clients inhale that through a mask, through the nose and the mouth. Yes, nebulization of a saline solution. When you nebulize a saline solution and you breathe in this saline solution, this stimulates expectoration. And after that, the clients can expectorate flames. But the bronchodilator is not producing this effect. That's why I inform you that this is not correct. Place the specimen, if you obtain the specimen, in the refrigerator until it can be transported to the lab. No, the specimen should be transported immediately to the lab. The bacteria that the growth in in the bacteria that growth in sputums are very fastidious, is the name that is used in microbiology, very difficult to grow, and the specimen need to be very, very fresh. So this is incorrect. Should be uh, should be immediately uh, mm, transferred to the lab. Tell the client to rinse the mouth with water before the specimen is obtained. So here, some of you could have a doubt. You see, okay, uh, the specimen should be taken in the morning. So this option is wrong. Obtain the sputum specimen before going to bed is wrong. First, because at that time you have scanned sputum. You have more sputum in the morning. And second, because the microbiology lab is usually available in the morning. So the moment to take a specimen of sputum at the ideal moment is in the morning. Nevertheless, sometimes you can have a stat order of sputum, and maybe it's not in the morning. So if you have a client arriving at 3 p.m. with a pneumonia and expectorating a lot of sputum, you take the sputum at 3 p.m. and send that to the lab. No problem with that, yes. But the ideal to obtain the sputum specimen is in the morning. Not always, but before going to bed is a nonsense. The microbiologic labs usually are not emergency labs, are closed. And if they are not closed, okay, it's very difficult to expectorate before going to bed. If there is a elective collection of sputum, is not an urgent collection of sputum. The best moment is in the morning. So this is the right answer. So maybe you ask yourself, why not rinsing the mouth with something stronger, like for example a mouthwash, or a toothbrush with a toothpaste. Okay, it's important to avoid antiseptics in the mouth before collecting the sputum that is coming from the lungs. You know that you have the bronchi, the trachea, okay? And the sputum is coming from the lungs, okay? The sputum is coming from the lungs. This sputum, when it's expectorated, is going through the mouth, no? Is going through the mouth, yes. And if in the mouth you have antiseptics like the mouthwash or the toothpaste, then the bacteria that is in the sputum is going to be killed. Is going to be killed. That's why it's okay to clean the mouth to decrease the contamination of the bacteria that is normally in the mouth. You can decrease that rinsing the mouth, but only plain water, plain water. Yeah, no antiseptic. So that's why this is the right answer. Just a review, because I never know if there is somebody that the day that explained that in fundamentals, okay, this person didn't go to class, and maybe there is a hole, there is a gap in the knowledge there, because this is what is happening, okay, with some people that go to the anchors and fail the anchors. Why? Because demonstrate in the anchors serious gaps in the knowledge. Okay, and sadly, the people that have gaps in the knowledge don't assist to the review. This is my personal experience, that the people that need those review, they don't assist to the review. The people with the gap, okay, in the knowledge don't assist to the review. But we do what honestly, as a school, as a university, we feel that should be done. Help the students, you know? So if you don't want to be helped, this is your problem. But it's also our problem. At long term, it's also our problem. Next question. The nurse in a pediatric outpatient care facility has received telephone messages for parents of clients who were previously seen in the facility. It's a common type of question in the English that you need to answer for messages, and you need to decide which message you need to, to answer first. Acute otitis media and reports insomnia after taking amoxicillin 6 hours ago. Obviously, this is not a priority. Yeah. Okay. They don't mention pain. It's possible they cause pain. Yeah, could be pain, but insomnia is not a life-threatening condition. No, it's not a situation that requires immediate reaction. Fracture of the left tibia, and the boy or the girl has placed a crayon in the cast. This is a big problem. Big common question in NCLEX and in any nursing test when there is a cast and the child is in this initiative versus guilt. Okay, so the preschool, no, the preschool that have this, and the toddlers also, of introducing objects in the most absurd places to see what happened. They introduce objects in the ears. They introduce objects in the nose, in the nostrils, in the nasal cavities. They even introduce objects in the vagina, the girls. Is something, it's a tendency that is a common at this age. And if they have a cast and they have something that can enter there, they introduce the object there to see what happened. Initiative, he called that. The initiative to explore the world, and of course now you have a crayons in the cast and they start making pressure, and then the mother start introducing a hanger wire to remove the and then they have a skin breakdown, they start bleeding, and the drama. Yes, it is, maybe. Okay, usually those requires removing the cast, opening the cast, removing the crayons, and putting a new cast. Could be very expensive. Gracia, no? Could be a very expensive situation. A colostomy and report skin irritation around the stomach. It is an issue that is frequent and need to be cared, need to be avoided, okay, with the proper management of the skin barrier, you know, and it doesn't sound like an emergency. And then we have a pneumonia, but has a pink frothy sputum. So now the crayon becomes less important, can wait, because now this patient with pneumonia is having a pulmonary edema, in that case associated with the pneumonia, which can happen. Usually, we are used to see pulmonary edema in heart failure, left heart failure, but also infections or irritations like inhalations. Also, for example, burns when we are in a fire and we breathe in, okay, the heat, burns of the airway, uh, infection of the airway, inhalation of irritants, you know, can produce pulmonary edema, non-cardiogenic pulmonary edema. Uh, and the acute respiratory distress syndrome that can be seen in sepsis, in infections, can produce pulmonary edema, non-cardiogenic, not related with the heart, cardiogenic pulmonary edema. When a person is spitting up pink frothy sputum, you need to suspect that the lungs are flooded with liquid, and the person is drowning in his or her own fluids. Yeah, and it's an absolute priority. So it is a question that is important. Recognize pink frothy sputum as a manifestation of pulmonary edema, and that knowing that the pulmonary edema is not exclusive of the heart failure, can be present in other conditions and are called non-cardiogenic pulmonary edema. The nurse is caring for a 6-year-old client who is receiving skeletal traction. So obviously they should give more information, but the most common skeletal traction is lower extremity skeletal traction, like a transient, okay, procedure before surgery, okay? And let's see, probably a femur fracture, no? Which of the following will be a priority for the nurse to monitor? So now it is an issue because they are asking the most important. I need, because I was reading this question before starting the meeting, and I found that the question was very difficult for me. I need your help. What is a priority? The distance between the client's knees, the pull of the traction on the client's, the degree of flexion of the client's ankles, the position of the client's cervical spine on bed. So if we have a child with a, for example, femur traction, okay, suppose that is the right leg, you are going to have something like this. You are going to have a pin. Let me change the color of the pin. A pin introduced here in this tibia. And then you are going to have a ropes. Um, Usually you have here a wedge, okay, a wedge that elevates the fracture leg and prevents the pulling action or the traction, pulling the clients. You know, this is the mattress, no? This is the mattress, no? This is the mattress, okay? Pulling the clients in the direction. So this is the role of this wedge that is over the mattress, elevating here, okay? The other leg can be also resting, okay? But it's not having the traction. The traction is only in the right leg. There are a rope, they make the rope green, a rope that is making a pull a force on the pin. So is tied to the pins and is making a pull action that is controlled by a pulley that change the direction of the traction in this direction. So now the direction of the traction is this, and then you need to have a weight that is always freely hanging in the air, always. No, no it's not important to have this, you know, balancing or moving side by side. No problem with that. Okay, it's really hanging on the air. No, this is the floor. Okay, so I try to make those drawing to trying to imagine this scenario. In the test, I think that you need to do that. Okay, I think that you need to do that. Okay, it's very important that the patient to be aligned. Okay, when the patient is aligned, okay, the head, the trunk, and the traction is in the same line. Okay, so the client should not be disaligned, should not be having the head here. Okay, okay, could not be having the head here, could not be having, the twisted leg, etc. So the client should be aligned. Cancel, no. ¿Qué es lo que yo quiero hacer? No, yo lo que yo quiero es borrar esta cabeza. Okay, it should be aligned. Okay, what else I can show here? Okay, so now that you see this, yeah, you see this, you have the distance between the client's knees. Okay, the separation between one knee and the other knee, the separation, the distance, the pull or the traction in the client's being. So this action here in the pins, the pulling traction in the client's beams, the degree of flexion of the ankles, the ankles, okay, um, the ankles give you a flexion called dorsal flexion, okay, and so this is the degree of flexion of the ankles, no? This is the degree of flexion of the ankle. And the position of the client's cervical spine on the bed. What is your opinion, guys, if you have this question in your English? It's difficult, no? Let's try to rule out, okay, the least possible. So if the client, okay, have the head twisted, it's going to produce a neck pain, but it's not going to be nothing serious. It's not a priority, no? So if the client, is, wants to know what is happening here, and is, twisting the neck to see what we are doing, maybe he's going to have some neck pain, but there is no fracture in the neck. There is no problem in the neck. So I don't know. I think that this is not the priority. Yeah, that the position that you will monitor the position of the cervical spine on the bed. Why is not a priority? Because there is not fracture. No, there is no fracture. There is not evidence of head and neck trauma. It is a leg trauma. We assume is a leg, traction. That's why I said that the question should mention where is the traction, but usually it's a leg traction. So if is it, we assume that it's a leg traction. The position of the client's cervical spine is not a priority, because if if it were a priority, then the neck must be immobilized with a neck collar, a rigid neck collar, or a halo vest immobilization. So that's the reason for which I think that the position of the neck is not important. Okay. Uh, the position of the two knees, so the distance of the two knees, okay, is the leg, the left leg, which is not fractured, okay, is so remember the pins are in the right leg, okay, in the right leg, okay, in the right leg. The pins are here. So the distance between the leg that had the traction and the leg that had no traction, I personally don't see what is important to keep X X distance between those knees, because the patient can be moving freely the non-fracture legs. So that's why I think that the distance between the client's knees is not important, because I insist the pins and the traction is in the right leg only, in the right leg only. The left leg is free to be moved. They don't need traction, okay, unless it is a Bryant. The Bryants need to have the two legs, but they are not mentioned here. There is a Bryant, okay. The most common is the box traction. In the Bryant traction, the baby is pulled from the two legs, okay, and then the body is separated from the mattress and need to be strapped to the bed. But it is overthinking. They don't say there is a Bryant traction. The most common is the bulk traction, which is the one that we represent. The question that is presented has this defect, is missing information, but is the most common is this, the traction is this. So I don't think. Then the pull of the traction on the client's pin. Always there is going to be a pull that is function of the weight, okay, the number of pounds that is in this, that is ordered by the doctor. What is important for the nurse, what is super important for the nurse, is that this weight is always freely hanging on the air. You don't care if moving. You don't care about that. This is not point problem, okay? Because the pulley is going to prevent any transmission of the movement to the traction, but it's freely hanging. But they say the pull of the traction in the pins, okay? So it is very important that is all time, okay, the traction maintained. I think that it is important because all time, 100% of the time, they should be a pull action, okay, on the pins, on the pins. And the degree of flexion of the client's ankles. If it is a fracture of lower extremities and there is a traction in the lower extremity, there is a complication that a registered nurse should know could happen, different from the compartment syndrome, and is the injury of the ulnar, pardon, ulnar, no, the peroneal nerve, peroneal nerve. You know that you have here in the legs the tibia and the peroneal bones, yes? And there is a nerve that goes through a peroneal bone, the peroneum, okay? And this nerve is necessary to do the dorsal flexion of the ankle. When a client have, as a consequence of the trauma or the traction damage of this nerve, you have drop, a drop foot. So the foot is going to be all time drop. You understand? Is 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 falling in this direction, a drop foot. So you notice that one foot is can be dorsal flex, but the other foot is dropping. And I I consider that it is also important because in tractions and in fracture lower extremities, the peroneal nerve need to be evaluated because it's with certain frequent damage producing a drop foot. So the foot is drop is unable to dorsal flex. So I have two important stuff here. I have something that should be constant and is standard and is continuous, should not be interrupted. That is the pulling force of the traction on the pins and the evaluation, okay, uh, the evaluation of the possible peroneal nerve lesion because a drop of foot that is observed when the degree of flexion of one ankle is decreased, producing a drop of foot. And that's why I personally find this question difficult. Will you be in your ankles in similar situation? Absolutely yes. Will you be in your ankles in the scenario of having two correct or possible answer and you need to decide between these two options? Correct. It is a reality. So you are going to be between two options, in between monitoring the continuous pulling traction in the client's pins, which is important to be kept all time in the traction, is a priority, but also is a priority to monitor any possible damage of the peroneal nerve, producing a drop of foot and decreased dorsal flexion of the ankles. And in these situations, I have deep doubt to decide. I personally taking the test, the question, or decide which requires higher priority. Okay, higher priority. And if I reading correctly and understanding that the uh, maintenance or the continuous pulled traction on the pins is a priority in the traction, probably I will be answering this, but I will be very unsecure, very doubtful that this is also important. Do you understand me? Do you have any comment?
I understand, Professor.
You understood? Okay. So the this question maybe is never in your English, but the message that I want to transmit is be prepared. Be prepared to be in this situation in your ankles because even people with certain experience like me will have this kind of doubt. And I don't know if you remember the 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 student that connected last time that we met that gave us a very good advice. This student have the test required to do the maximum number of questions. And in some moments, she felt tempted to give up, to stop fighting. But then she decided to continue fighting, to answer each question, even the 170 question, okay, as intensely, as carefully as if they were the first question or the question 80, 84. And then, do you remember what she said? At the end, I passed. So uh, you never during the test should give up. You never in the test, you should be rushing. What is rush? When you feel that you are done, when you feel that you are too tired, then when you feel that is too much for you, and you start answering the question very fast to finish the test, to get out of this and go to have a coffee or go to have a ice cream, okay, or have a drink because you feel frustrated or uncomfortable, you don't feel happy with yourself. Don't allow those feelings to take you during the test. Fight like a good fighter. Fight like like a good competitor and until the end. Because even having the maximum number of questions you can pass, I have important number of students that have been my students that they passed with the maximum number of questions in the test. Remember, meanwhile, the program is giving you a new question because you still can pass. If they already know that you cannot pass, they stop the test. So have this mental attitude, okay? And the other recommendation that I always, hey, you don't need to get 100 to pass the test, okay? I have a bunch of students that pass the test, even with 85 questions. And then when they comment me some of the questions, they say, you selected the wrong answer. You failed this question. And even being short by the book that they fail questions, plural questions, they pass the test with the minimum number of questions. It convinces you that you don't need to get 100 to pass the test. Okay, so it's also part of the coaching for the test, coach attitude for during the test. What is important is to fight, to give your best. For the new question, try to do your best. A new question, try to do your best. Don't rush. Don't adopt this attitude of responding the first that sounds familiar just to get out of the test. The nurse is collecting data from a client with acute myocardial infarction. Which of the following findings will be consistent with an acute myocardial infarction scenario that apply? Nail bed. You know what is nail bed? What this pink stuff that you see under your nail, no? Splinter hemorrhage. I don't know if you know what is that, okay? But you should know what is a splinter hemorrhage. A splinter hemorrhage. A splinter hemorrhage is like this. Is a hemorrhage under the nail that looks like a splinter were introduced under the nail. Splinter is una astilla for the people that like me. English is not the first language. Okay, splinter hemorrhage. Okay, has different etiologies, but the most important is endocarditis. You studied bacterial endocarditis. Splinter hemorrhage is a finding in bacterial subacute endocarditis and acute endocarditis. It's a very important sign in endocarditis. Okay, so for those that don't know what is a splinter hemorrhage, associate this with endocarditis. So it's not a manifestation of myocardial infarction because myocardial infarction is not associated usually with endocarditis. Nausea and vomiting. The patient with myocardial infarction could have nausea and even vomiting, but it's not a typical. So if I were taking my test, I don't choose nausea and vomit as something consistent with myocardial infarction. It is true that they are atypical, okay, atypical, okay, manifestation of the myocardial infarction, especially in diabetic clients, very old clients, and women. Women are always, having, different symptoms. Okay, so this is possible to have a myocardial infarction with digestive symptoms, but it's not the common. It's the exception that need to be taken in consideration because you should not be sending home somebody with a atypical presentation of myocardial infarction like indigestion with antacids having a myocardial infarction. So always when you have a diabetic, very old person or women with atypical symptoms, you always can rule out among the many differential diagnosis an MI that can be easily ruled out with an EKG, and a nurse can do an EKG in 5 minutes. You know? But I wouldn't be, marking this because it's not consistent, typical of MI. But diaphoresis, that means profuse sweating, is very common in myocardial infarction. This happens because the drop of the cardiac output. The myocardial infarction affects commonly the left ventricle, and the left ventricle is responsible of pushing, moving the blood into the arteries, producing the blood pressure and the cardiac output. Yes, and because this muscle, this left ventricle, is partially damaged, then the cardiac output decreases, and the blood pressure could decrease, or at least could be, less than normal, less than usual, no? And it produces the diaphoresis. And the dyspnea can have the same manifestation because the left ventricle moves the blood in this direction, in the direction of the aorta. If the blood is not efficiently moved in this direction because the left ventricle is infarcted, then the blood pull can build up backward, can backflow to the lungs, you know, that are, before the left heart, and then the blood can builds up in the lungs, producing pulmonary edema and dyspnea. That's why dyspnea is is consistent with left ventricle myocardial infarction. Petechiae is not a manifestation of myocardial infarction. Petechiae are those red multiple, pinpoint small points in the red or purple in the skin that suggests one, low platelet. This is one cause, okay, of petechiae. Two could be trauma. Trauma could produce petechiae. Three could be fat embolism. Everybody studied that when you have petechiae in presence of a long bone fracture, it could be fat embolism. Could be also a manifestation of bacterial endocarditis that can produce also embolization in the skin and petechiae. What else could be a cause of petechiae? Yes, decreased thrombocytopenia, trauma, fat embolism. Yes, bacterial endocarditis are frequent causes of petechiae, but not myocardial infarction. So this is the two options that I should mark in that. When you have a select that apply question and you have doubt in one option, leave it blank. Leave it blank. Because if you mark an option that is wrong, you will be penalized and they will cancel or eliminate one right answer. So it's better business, okay? If you are not really sure, to leave that blank, okay? You are going to have partial credit, but for the one that you answered correctly. It's a strategy. The nurse is caring for a client who sustained a closed head injury, head trauma. Which of the following findings require immediate intervention? So the head trauma, you know, is going to be the trauma first in the skull, but then is going to be the trauma in what is inside the skull, that is the brain, you know. So the head trauma could be something mild, and then you only need to observe the client, and it's the case of something called concussion. Okay, concussion. Yeah, the concussion. Something missing. I think I see concussion. Okay, only knee observation. The head trauma is minimum, but sometimes the head trauma can be more serious. Sometimes the head trauma can produce a hemorrhage. Okay, between the skull and the brain, could be epidural or subdural. Especially the epidurals are very risky. Or the head trauma can produce a contusion. Contusion. Contusion means that a part of the brain, okay, part of the brain is having a trauma, and then is having, a contusion, having a bruise inside the brain, and then the brain could be start malfunctioning. Even the endocrinal pressure can increase. So this is what can happen in a head trauma. Yeah. Okay. So now we have this, a blood pressure that have systolic hypertension, but a mild systolic hypertension, and we don't have comparison. We don't know how it was before the head trauma, and we don't have the heart rate. Ecchymotic area, ecchymosis is a bruise over the left temple. Temple is this side, okay? Temple, where is the temple? In the temporal area. Yeah? Is in the temporal area, okay? Behind the orbit is the temple. Headache that worsens when coughing. And Glasgow Coma Code 13. Okay. So what do you think of this four finding is the most serious?
Two. Ecchymosis.
I couldn't understand you. Repeat because there is a lot of back.
Ecchymosis
Eso.
over the left temple.
Ecchymosis in the temple. Okay, what part is affected if there is a bruise in the temple? The skin, the skull, or the brain? If you have, let's see, and let's see if it can help. Okay, ecchymosis, temple. Let's see if I can unlock it. Okay, so this is not a temple. Oh, this is the temple. This is the temple. Okay. No, it is periorbital. It is not. Is not. Is not. Is not. Is not. The only ecchymosis in the temple that I have is this. Okay. If you have a bruise in this area, what what part is affected? The skull or the brain?
The skull.
Why the skull? The fracture of the skull. The fracture of the skull give you the raccoon sign, which is this. No, this is not a temple. It's periorbit,
Professor, I
periorbital
can't
bruise.
see the. I can't see the screen.
Nobody can see this. Nobody can see the picture.
Yes, I see.
No.
I see the
Yes, I
picture.
No,
never.
I can see. No, I
No,
can see.
I can't see. I cannot see.
Me
Okay,
neither.
I'm going to to stop sharing and share again to see if now you can see. This program is horrible. Now, can you see the picture?
Yes.
Yes, it's
Yes,
good.
Professor.
Yes.
Okay,
Yes.
this is the raccoon sign. See, the raccoon sign is a bruise in the orbit, the palpebral and periorbital side. But I was showing, okay, temple. This is the temple, you know, la sien, decimos en español, temple. And this is how it evolved in this client, no? This is the temple. This area of the temporal bone here is the temple. You can see that, you can see the temple, yes or not?
Yes. Yes.
Yes,
Yes.
okay. So if you have a skull fracture, you have the raccoon sign, or you have the battle sign. Where is the battle sign?
Behind the ear.
Behind the ear. So the battle sign is behind the ear. It's not in the temple. It's the mastoid area. Okay, it's behind the ear. Okay, it's behind the ear. This is those are the signs. Okay, of basilar skull fracture, the most frequently fractured part of the skull. So, a ecchymosis in the temple could sound very impressive. Okay, but it is the skin. It is the skin that what has the problem. We need to look to problems in the brain, not even problem in the skull, hueso, bone, skull is important. The important is the brain, because
The number.
I can have a fracture in the skull and the brain can be okay. So
Number 3.
headache that worsen with coughing, it is important, is a priority.
Yes, I see.
Yes.
No,
Why not?
because
It's letter A.
did you
I
ever
think.
did you ever have headache and then when you sneeze or cough you feel that it's more painful? Never? Nobody?
Yes,
Yes,
Professor.
Professor.
Okay, if you never notice that when you have headache, because everybody have headache from time to time, when you sneeze or cough it hurts more, it is not a concerning sign. It is not a concerning sign. Okay, so if you have a head trauma, you have a head trauma, do you have headache? Yes or not? Is it normal to have headache? Yes. It's expected people have
Yes.
headache? Yes.
Yes.
And if you cough and having headache, you have a head trauma, you have a head trauma and you have headache, it is necessarily the priority? No, because you expect to have headache if you have a head trauma. And if you have headache because you have a head trauma, and then you notice that when you cough, the headache worsen, intensify, is expected. It doesn't mean a priority. It doesn't mean that the brain is injured. I don't know if you agree with me, but I'm convinced what I'm saying. This is not a priority. Ahora, what happens when you have somebody with headache and the systolic blood pressure increases and the diastolic is not increasing?
Professor, that's the wine and blood pressure that happened in Cushing triad.
It could be a Cushing triad. Could be a Cushing triad. What is missing is the, ¿cómo se llama? The heart rate to see the bradycardia. And what is the normal Glasgow Coma scale?
15.
15.
15. 13 is normal?
No.
It's fine.
Well, but it's not so bad.
It's
Okay, but it's not normal. If, excuse me, God forbid, but suppose that your boyfriend, your husband, your somebody that you is important for you has a head trauma, and when you do the Glasgow Coma scale, you don't obtain 15, you obtain 13. Would you be concerned? Yes or not?
Yes.
Of course that yes.
Yes.
Of course that yes. If you have a head trauma, you have a head trauma, okay, and then you have 13, you should be concerned, okay, because 13 is not normal. It's not serious. You are not in coma. It's true. But you should not consider like reassurant having 13 Glasgow Coma scale after a head trauma. So the two possible options to consider as answer in this question are this and this. If you have a decrease, Glasgow Coma scale, 14, 13, 12, what is the part of the head that has been affected? The skin, the skull, or the brain?
The brain, right?
the
Of
brain.
course that the brain. Of course that the brain. Because the brain is what gives you your level of consciousness. Your skull doesn't give you your level of consciousness. You can have a skull fracture and be totally, conscious with Glasgow 15. But if your Glasgow is 13, there is a problem in your brain. So this interpretation, but 13 is not normal, but it's not so bad. It's not good. Are you going to wait until the client is Glasgow Coma scale 7-6 to be concerned? It's concerning having a Glasgow Coma scale less than normal after a head trauma. Definitively. Yes, definitively. And then we have the blood pressure. Blood pressure 166 6/76 could be two problems. Cushing trauma, Cushing triad, sorry. Cushing triad is a possibility. And the other is activation of the sympathetic nervous system because pain, fear, etc., anger, etc. So this elevation of the systolic without elevation of the diastolic could be a Cushing triad, beginning of a Cushing triad of ICP, increased intracranial pressure, or could be pain, uh, fear, uh, anxiety, etc. So is less significant from my point of view, less specific than having an abnormal Glasgow Coma scale. So another question in which you are left with two possible options: an elevation of the systolic without elevation of the diastolic. That could be a Cushing triad. You need to find other elements of the Cushing triad, like the bradycardia, that maliciously has not been mentioned in the question. Okay, versus having a non-normal Glasgow Coma scale, which is concerning because translate there is a problem in the brain, and this is definitive, it is objective. Any person that have a Glasgow Coma score of 13 is having a problem, not severe, but is having a problem in the brain. For that reason, because it's, for me, from my opinion, is I conclude that this Glasgow Coma scale is abnormal and it translates a brain problem. For me, the most concerning is the alteration of the level of consciousness. Yes, go ahead.
Yeah, I agree. I was gonna say I would choose 4.
Yeah. So, but do you realize that this is an Nclex style question, that we are left with two possible answers, and then we need to decide which one of the both is the best?
Yes,
Okay,
yes, of
so
course.
this is a very common situation in English. Believe me, it's a very common situation in English. So expect, be ready, be prepared that in English, some questions you are going to be answered immediately, right, okay, straightforward, because you know it's an easy question, okay? But sometimes they give you questions like this that you are left like thinking of the possibilities, okay? You should avoid overthinking, but it is a correct thinking, okay? We're thinking that we made is not overthinking, it's our correct thinking, okay? So yes, we have here a tricky question, a difficult question. Those questions that are difficult weigh more points than the question that you can answer immediately, like like this one, or the the other that like a pink fluffy Python that can be answered immediately. So when you answer these questions, the pink fluffy Python or the you peep standing, you gain time, because you have 2 minutes to answer this question. You answer the question 1 minute, so you gain 1 minute, and then this you gain another minute. You have 2 minutes gain to dedicate to dedicate to these more difficult questions. So obviously it's good to discuss this, because if you have experience, you know that the head trauma, a headache is expected. Yeah. If you have, you fall and you have a bump in your head, you have a head trauma, a closed head trauma, okay? A closed head trauma. Is expected to have a headache? Yes, you have a head trauma. And then if you cough, the headache becomes more acute, more intense. for the moment that you cough, yes, of course, because when you cough, you're increasing intracranial pressure and it becomes more painful. It is expected. It is a distractor. And I don't know you, but in mi pueblo, in my culture, when people got had in the popular belief in the street, the lay people, no, when they have a trauma in the temple, they say that it's a very delicate area because the skull there is very thin, because you have a sunken area there, and people think that there the brain is not protected by the bone. And I'm pretty sure in NCLEX they use a lot of belief, lay people, people not nurses, okay, lay people without medical knowledge, okay, believe that the trauma in this sunken area of the temple are riskier than in other parts of the skull, which is not true. And that's why this ecchymotic area in the temple is not related neither with raccoon sign nor with battle sign. It's another distractor. So we did a good selection when we, discussed the question between 1 and 4. But one could be anxiety. One could be the pain. Pain and anxiety elevate the systolic because activates the sympathetic nervous system. How should be the heart rate if there is pain or anxiety activating the sympathetic system? Should be elevated. How should be the heart rate if this were a Cushing triad?
Lower?
Lower, because the Cushing triad is elevation of the systolic, normal diastolic, and bradycardia. So do you notice that I'm being insistent that they are maliciously withholding information? They should give me the heart rate. Do you realize that?
Yeah.
Uh, so it is. I don't think this question will repeat to nobody in their English, but the topic, the discussion is useful. The nurse has attended a staff education program about elder abuse. The following statements by the nurse would indicate a correct understanding of the teaching. So we are going to look for the right answer, the right option. A healthcare worker or family member who threatens to withhold food, water, or medical care is committing a form of abuse. Yes, it is true. Too easy. Okay, I'm paranoid, too easy. Okay, the nurse should explain to the victim of elder abuse that data collected about the abuse will be kept confidential. Not true. Cannot be kept confidential. Need to be reported. Do you agree, no?
Yeah.
Client,
Yes.
okay, of course. Client who are physically disabled and living in long-term care facility are the typical victims of elder abuse. I don't agree. Okay,
No.
in nursing home is a living long-term care facility. Should not be the place where usually elder abuse occurs. Fin de mundo, could be el colmo, no? That in the nursing homes is the most common place where elder abuse occurs is unacceptable. That's why ACA is having a hotline that allow you to report any abuse, and confidentially, if you are a nurse, you know that I had to do that once when I was LPN. Yes, when I was LPN. When I was LPN, I witnessed an abuse from a CNA to a male CNA to a old lady in nursing home. I documented and I reported to the my supervisor. The supervisor didn't report the CNA, so no action was taken. So I simply called ACA and I reported the situation. I had already documented in the chart of the client what I witnessed with factual, well documented. And of course they proceeded. Okay. And but it's not the most common to have there a lot of protection that prevents this abuse in the nursing homes. Doesn't mean cannot occur, can occur in closed doors, and we need to be aware, because those clients cannot defend themselves, no. And so, but I disagree totally. It's not the most common place of abuse, and other adults who are abused will readily explain the situation to healthcare provider if asked directly. It's not true. You know what? The abuser generally is a child, a nephew, okay, a relative, yeah, and they protect, the old people protect the abuser. It's like women, that women protect the male's abuser in intimate partner violence, you know, is something similar, but even more frequent in elder abuse. That's why don't expect that they are going to disclose the abuse and the abuser readily, easily to you. You need to be very insisting in that. I hope that you understand what I explained. So definitively the answer was very easy. In number one, if you say, I'm not going to give your supper if you don't shower. I won't give you the snack if you don't take the medication. I won't give you the pain medication if you don't take the blood pressure medication. Okay? Those are forms of abuse. In this case, when I speak this way, what I'm doing, battery or assault?
Assault.
Assault.
Assault. Assault. Because it's a verbal threat. Yeah, it's a threat without touching. Okay, very good, very good. Each time that you improve in demonstrating knowledge of legal issue, etc., you increase your chance of passing the NCLEX. Lindo. The nurse is caring for a client born 6 hours ago and observe this sign. Which of the following action should the nurse take? Notify the healthcare provider of the finding. Administer oxygen, already prescribed PRM. Continue to perform routine newborn care. Prepare the client for phototherapy. What is the best action here?
3.
3,
3.
because it is acrocyanosis, which is expected in the first 24, 72 hours of life. Nevertheless, I always disagree with nurses that write those questions. Now, my intervention is cover those poor feet, because those feet are cold. That's why they're having vasoconstriction and acrocyanosis. So I know that is nothing serious. I know that is nothing to be reported, but requires an intervention from me and needs to cover this child. This child is cold. I disagree always with the question banks about this issue. There is something to do, not continuing and ignoring the sign. Please cover those feet, cover those hands. The client is cold, and cold is not good for babies. It's not a serious cold. It's not hypothermia, but is something that I assume produces discomfort in the baby. That's why they cry. The nurse is contributing to a staff education program about confidence. It's no? Okay. Okay. No, it's different. The client, the nurse is contributing to a staff education program about confidentiality. Which of the following information should the nurse suggest including? Clients must wait until after discharge to view your medical records. Agree or disagree?
Disagree?
Disagree. They
Disagree.
can be see that they can obtain a copy of the medical records in any moment, not after discharge. Clients must disclose all personal information in order to receive care. It is an absolute. We
No.
automatically, with the absolute, becomes, prejudice. But, exceptions occur. But in this case, we are good. This is unacceptable. There are personal information, like if you have a lover in your life when you were, very young, you don't need to disclose this information to receive care because it's not pertinent. It's not pertinent for your problem. You understand? So disagree. Your common sense. You don't need to study a book to answer those options. It's common sense. Nurses in a hospital unit may review the medical record for all clients in that unit.
No.
No, you only review the medical records of your assigned clients, not all the clients. Certain information in the client medical record may not be considered confidential.
No.
If the client has gonorrhea, must be kept confidential and not reported to the Department of Health.
No,
No.
Need to be reported. If the client is threatening, is commenting to you that want to commit suicide, you keep that confidential? No.
No.
If
No.
the client is threatening to kill somebody, it can be kept confidential? No. So that's why this is the answer. Certain information, some information, okay, may not be considered confidential, need to be disclosed to who need to know. Okay. So here I notice a difficulty in the wording, in reading comprehension, especially for people like me that English is not the first language. So I could notice certain confusion in the wording of this question for some people, but at the end it's clear. So some information, like the examples that I mentioned to you, cannot be kept confidential. The nurse and a CNA are caring for assigned clients. Which of the following activities will be appropriate for the nurse to assign to the CNA? Applying a condom catheter to the male client with a fraction who is incontinent. Applying a pressure dressing to the right hand of the client who has a stab wound. Obtaining vital signs for the client who is experiencing delirium tremens. Inserting a nasogastric tube for the client with anorexia nervosa. We can quickly rule out the nasogastric tube, and we can quickly rule out the dressing because it is beyond the scope of a CNA. So now we have the condom catheter, which could be possible, and the vital signs. So which one you decide is the best for delegate to the CNA?
3, I think.
Okay,
One.
notice that this client is experiencing delirium tremens. Delirium tremens is a very severe acute condition that have a severe autonomic nervous system instability. The client have tachycardia, hypertension, um, tachycardia, hypertension, cardiac dysrhythmias, hyperthermia, risk for rhabdomyolysis for hyperthermia, has a risk for seizure. Is a very delicate client. When we
Yes.
have such a delicate client, they have a very high mortality. They have hallucinations, a lot of hallucination. And when you have those so unstable clients, the vital signs should be taken by the RN because it's an exception. So it's better a condom. A condom can be placed for everybody, please. A condom can be placed by everybody. And a condom catheter is a condom, but the difference that is connected to a tube that goes to a bag. This is a condom catheter. Okay, so it's a condom in the PP. Yes, it's a condom. Okay, connected to a tube that go to a bag. It's a non-invasive method of control or management of incontinence, urinary incontinence in males. It's very useful, and is in the scope of practice of the CNA. Is in the scope of practice of the CNA. Guys, you are going to forgive me, but I'm going to stop here because I have a lot of sore throat and and discomfort. So next time I promise to be okay and continue practicing this question. Okay.
We understand,
Thank you,
Professor. Get well.
Professor.
Okay. So see you next
Feel better.
time.
Thank you.
Feel better. Thank you.
Thank you. See
Bye.
you next time, and that's it. Okay.
Okay, take
So
care of yourself.
thank you for your attention. Okay, let me see people, people, and download attendance list. Okay, yeah, thank you. Bye bye.
Bye.